Thank you so much, Anthony, for inviting us to give you the New Zealand perspective on uveal melanoma. So, as we already heard today, and you know, the uveal melanoma is the most common primary intraocular malignancy in adults and accounts for 3 to 5% of all melanomas. The most common site is the choroid, and it's more common in male than female, and the median age at diagnosis is about 62 years. So let's talk about how common the uveal melanoma is globally. So this is US, so the incidence of UM in the States is about 5 overall. That's 5 cases per million per year. But when you look at when you break it down to different ethnicity, as you can see, the non-Hispanic white people have higher incidence or higher rates of UM compared to Hispanic, Black, or Asian populations. In Europe, the incidence of UM increases with the latitude of the country. So in Spain and Italy, it's about 2 cases per million per year. And that goes up to more than 8 in Denmark and Norway. So what about in New Zealand? I think our estimation is about 10 cases per million per year. And if you look at different populations within our population, Maori and Polynesian people have lower incidence, as you would expect. I think Australia, it's about 8 cases per million per year. Similar to Denmark and Norway. And in Asia, down in there, they see South Korea, the rate of UM is very low. Now, total New Zealand population is only 4.8 million, so we are very small compared to Australia, and 1/3 of our population live in Auckland, that's where we're from. And the next 2 largest cities, Wellington and Christchurch, only have less than 500,000 in each of them. We have 20 district health boards across the country. We have 3 DHBs in Auckland itself. So that means if you look at the incidence rate of 10 cases per million, that means we have roughly about 40 cases of UM per year. So we're pretty small compared to Australia. But we do have centralized referral system. So if a UM is suspected, they get referred to ocular oncologist in Auckland. So there's Peter Haddon, who unfortunately couldn't make it today due to other commitments. He does most of the choroidal melanomas. And we have Professor Charles McGee. He specializes in iris melanoma. So patients are seen either in the public system in Auckland DHB, Green Lane Eye Clinic, or if they are medically insured, they can go to a private clinic and see either Peter or Charles there. So once the diagnosis is made, then obviously they have discussion with Peter or Charles about the options. About half of the patients currently undergo brachytherapy using ruthenium plaques, and about 1/3 of the patients have enucleation due to the size of the tumour, or sometimes, quite often it's the patient's preference. Some people just like the tumour to be gone. And then about 1/6, so about 17% of the patients get referred to radiation oncologists in Dunedin, and they receive stereotactic radiation therapy. And very rarely, I think it's about 1 or 2 cases per year, go to Liverpool in the UK for proton beam radiation therapy. So I'll pass to Amanda for the next bit.
So Catherine and I are under no illusions that by inviting some New Zealanders to the meeting, it becomes from an Australian meeting to an Australasian meeting. And I have heard, I think, at least one other New Zealand accent of origin, and I did have a little chuckle to myself in the reference to our accent, because for those of you who don't know, there was a worldwide study done, and the New Zealand accent is supposed to be the sexiest in the world. I'm not sure that those of us from New Zealand think so, and definitely I'm sure those of you in the room would agree with me that something French or Italian certainly sounds a bit more exotic. But anyway, I'm going to present to you on just some of the laboratory findings, and this slide that I've put up here was a slide that I've referred to in talks previously, but as happens when you get older, I had a look at the reference, and it's 2008, and before I know it, 10 years have obviously passed me by, but I have, in researching the literature again, in case that there's been a slightly better schematic, I haven't been able to find one. I did ask Peter Haddon if he'd said anything better, and he said no, he thought that was probably about as good as it gets. And as he's not here, if I've embarrassed myself in front of Bertel D'Amato, who, as far as we're concerned, is the god of ocular melanomas, I can blame Peter, because he's not here to say otherwise. So anyway, as we've seen today in numerous slides, there's a lot of molecular changes that occur. I'm more interested in the far right side of the table, where we're looking at genetic change that is detectable in the diagnostic laboratory. We know that they can subclassify the melanomas dependent on some of these genetic changes, and that these genetic changes may indicate potential for metastasis. At the time that this paper was published, there was a clear mention of a bifurcation of the pathway, where you either developed a monosomy 3 or a 6p gain, and then you could rejoin the monosomy 3 group by gaining a monosomy 3 after the 6p gain, or a 8p loss. But in the clinic, what we found is that we do actually have patients that also have a monosomy 3 with gain of 6p. So, and I know Bertel had when he flicked up his slide, I thought, oh yay, amongst your 3,000 you had a few that did the same thing. So it's also good to know that our science is also on par with yours. So there is, 10 years on, although a lot of the stuff that is in here still remains consistent, I would question whether that's an accurate pathway. So as we've said, you've got copies of chromosome 3, 2 of them will give you a low metastatic risk. You've got beneficial gain of 6p. You've got your class 2s with high metastatic risk, and they're further subdivided into 2As, 2Bs, 1As and 1Bs. So up until 2016, we were doing FISH testing, and unlike some other laboratories which are doing it on fresh tissue, our FISH testing was on FFPE, and that's been driven more by location. Because obviously we're getting a lot of samples from across New Zealand, and it's not possible to get a fresh tissue from down in the depths of the South Island up to us here in Auckland while it still remains fresh. So FFPE, for practical reasons, certainly remains our tissue of choice at the time. We looked at VHL as a marker on 3P, RREB1 on 6P, MIB 6Q, MIC 8Q, and we had centromeres for 3, 6 and 8. Our genetic abnormality rate by FISH was 82%. And I know Svetlana put some lovely pictures up using her BAP, so just to show that we can do it as well as the Australians. These are FFPE sections. Here we've got 2 cells here with monosomy, so VHL is in green, and that's on 3P, and the centromere is stained spectrum orange, but to me it looks red. But anyway, we've got 1 copy of each, indicating that you've got 1 monosomy for 3, and likewise in this cell. We also looked at MIC copy status, and the probe set for that. MIC is in spectrum orange or red, and you can see you've got gain of 8 of MIC, indicating gain of 8Q, because you've got more than 2 copies of 8Q, but you've only got the centromere 8 is in aqua, so you've only got 2 of those. And IGH is there as well, because the probe's actually a Burkitt lymphoma probe, has 2 green signals. So you can see you've obviously got gain of 8Q. And then when we look at chromosome 6, we've got RREB1 in spectrum orange. We've got 3 copies of that, so you've got gain of your 6P. You've got 2 copies of CCND1, which is on chromosome 11, 2 copies of MIB, which is on 6Q, and the centromere is aqua as well. So that's indicating gain of 6p. And these things, I have to say, obviously we always pick the nicest pictures, the nicest images on FFPE. They don't all look like that. It is technically very difficult to analyse most of the time. With changes in technology and better ways of looking at things, we moved in 2016 to using a CGH plus SNP array. Again, this is also been looked at by our colleagues in Sydney Pathology, who use a different platform but same principle, where we look at 8 samples, we look at 60,000 probes, and we've got a practical resolution of 180 kbs. We look at it using some software, and the abnormality rate is comparative to that of our fish. Okay, so we're still seeing around 84% abnormality, but the difference between this and the fish is that this is a genome-wide screen. Okay, so we're looking at all of the chromosomes, and rather than karyotyping them manually down the microscope, which has its limitations, we produce essentially a computer-generated karyotype. So here's just a couple of images. Again, my software is slightly different to Svetlana's. Hopefully I've just given you the simplified version. If you see here, each of the chromosomes are labelled here, 1 to 12 on this top one and 13 to an X and Y here. It's a log2 ratio, so where you've got equal numbers of probes, you should see everything hovering around this middle line. If it moves to the left, you've got loss, and if it moves to the right, you've got gain. So in this example here, we've got monosomy for chromosome 3, and we also have loss of 1p. And then we've also got gain of 8q here. Okay, so obviously we know with the melanomas and what we're looking at, it tends to be whole chromosome, or either a whole chromosome loss or a whole arm, or I was going to say all leg, but technically they're both arms, gain here. Things that we wouldn't have been able to see just by fish, because we were only looking at the specific areas that we looked at. And I put another one up of interest. We've got monosomy 3 here. We've got gain of 6p. We've got we've got 8q here and 8p up there. Sorry, this is a bit, okay. So we can see all of these things. This is from FFPE tissue as well. Okay, so again, unlike you guys here who are doing fresh tissue, we're doing these on FFPE samples, which are notoriously quite ropey, but I certainly think that if you cannot get fresh tissue and you want to look at it, you certainly can look at it and get good results from an FFPE sample. So since going on the array, we've looked at 45 samples, 38% of monosomy 3, 1 sample has partial monosomy 3p, got 6 samples with concomitant gain of 8q, and then we've got 3 of these samples with concomitant gain of 6p in a monosomy 3 background. So obviously that pathway of 10 years ago isn't as accurate. I think one of the difficulties that we have with the New Zealand perspective of things, and it's important to acknowledge, is that Māori in particular are not very willing to undergo testing on samples that have been removed from the body. So those people who are Māori and have had an enucleation are unlikely to consent to this kind of testing, because they believe that the eye needs to be returned back to the body for spiritual reasons. So it can be difficult as well to get samples from these people. But you can see that in the 45 samples that we've looked at, given that only 30% of people are now having enucleations, we're getting the majority of samples. And for us and our small sample sizes seems to work well. So one of the other issues that we've got now is, because less and less people are having enucleations, can we look at other ways of still providing that same kind of prognostic information? These photos come courtesy of Victoria Cohen in London. I used to work in London, and St Bart's in London was a referral centre for retinoblastoma and uveal melanomas. So most of our samples we got there were aspirates. They weren't FFPEs, and we were able to do fish quite easily. Now technically with the aspirate there is an issue from the lab perspective. in that we need, in order to do these newer technologies like CGH and snipper aids, we need a reasonable amount of sample, and that can be technically quite difficult from an aspirate, whereas with a FISH technology, you can look at 100 cells and see abnormalities, or even 50 cells. If you see a monosomy 3, it's there, unlike with the FFPE where you've got to account for cutout and artifacts. So one of the things here, and I was speaking to David at lunchtime when he was showing his aspirate, and I watched in the movie, it was pulled into a really long 5mm Falcon tube, which filled me with horror, because I think technically, if you can get it into a smaller vesicle, which is what we use, a 1.5mm, 2mm Eppendorf tube, you've got much greater chance of recouping as many of those cells as you possibly can, which could be crucial downstream if you're wanting to do molecularly targeted therapy.
So, as you all know, there's some features of there's some clinical factors that's associated with developing distant metastases and poorer prognosis. As you know, there's some, these include age, ciliary body involvement, and tumour size, as in thickness and basal diameter. And as you heard, chromosome 3 status and gene expression profile classes. So if you go by the tumour size, by AJCC size category, as the tumour size increases from T1 to T4, the long-term survival drops significantly. Also, same goes with the anatomic stage, so that's based on size, ciliary body involvement, and distance of extraocular extension. So from stage 1 through to 3C, the survival drops quite quickly. So patients who are treated by the radiation therapy modality like brachytherapy and stereotactic radiation therapy are monitored quite intensely for tumour regression for the first few years. And the more longer-term follow-up depends on the response of the tumour to the therapy and also to the treatment complications. In New Zealand, just like anywhere else, we don't actually have any consensus on systemic surveillance. It's very variable, between practices, and because of the public health dollar resource issues, a lot of the DHB, like public patients, they don't get their surveillance done by any specialists, so their surveillance tends to be with their GP. For those who medically, has some private medical insurance, or they have the means to pay for the public as a private surveillance, then they go to private oncology clinic. And I tend to do 6-monthly clinical reviews as well as liver-specific imaging, either with liver ultrasound or MRI scan, and LFTs on bloods and chest X-ray. So this is the NCCN guidelines you've all probably seen, and here the systemic imaging surveillance is based on risk stratification. Now, when we detect metastases, most often in the liver, obviously the first question is it operable? Is it resectable? We have a really good liver surgeons, fortunately, and the liver resection and ablation therapy can be done in Auckland, Dunedin, Christchurch, and Wellington, but I have to say about 2/3 of the cases are done in Auckland. We can also do CERT, and it's available in Auckland. So Liverpool experience suggests that those people who can be resected, about 30 to 40% of the people can have longer term survival. So there's no standard of care when it comes to systemic therapy. As you heard today, there's no effective systemic therapy. And another challenge we have in New Zealand is that because it's so rare, we don't actually have any clinical trials specific to uveal melanoma. But patients And as well as doctors, we are very interested in participating in clinical trials, and it's actually really nice to hear that you have some clinical trials that maybe we can refer patients to. But off-label or outside of clinical trials, we do have treatments like immune checkpoint inhibitors and other cytotoxic chemotherapy drugs, but often they don't work. So in summary, in New Zealand, the incidence of UM appears to be high, but it is still quite rare, as we only see about 40 cases a year. And we have centralised referral centre in Auckland, and half of the patients are treated with plaque brachytherapy. In those situations, we don't tend to get a biopsy. But whenever we have tissue available, we would like to do we do additional cytogenetic testing, mainly for prognostication. Systemic surveillance is very variable, and clinical trial options are limited. So we are very keen to collaborate and work with you and send you some patients if that is feasible. So yeah, look forward to working with you guys. Thank you.